Healthcare innovation doesn't always start in a lab. Sometimes it starts at a bedside, or in a waiting room, or simply with a drive to discover more, to do more. Healthcare entrepreneurship isn't about innovation for innovation's sake. It's about seeing a problem that's been accepted far too long and deciding it doesn't have to stay that way. And here at Ohio State, some of the most impactful healthcare innovations are being led by people who know the system from the inside. I'm Matt Stessner, and you're listening to Now at Ohio State. We talk with researchers, innovators, and bold thinkers who look at our world, see what the real challenges are, and create the solutions that people need now. Our guest today is one of those innovators. Shannon Gillespie is an associate professor in the College of Nursing at The Ohio State University. She's a nurse scientist who leads a research team that developed a blood test capable of predicting the risk of spontaneous preterm birth with unprecedented accuracy. Now, this isn't just a scientific breakthrough. It's an incredible shift in how we care for mothers and babies, and a powerful example of how research can move from discovery to application to real-world impact. In her conversation with R. Ross Bischoff, she talks about the personal journey that led her into maternal health research, why preterm birth remains such a persistent and dangerous problem, and how her team is working to turn years of science into a clinical tool that could change care around the world.
Shannon Gillespie, thank you for doing this today.
Absolutely, yeah. Thank you so much for having me. I'm excited.
So just give us an idea of what you do.
I'm a nurse and a scientist. I do science in the area of nursing and healthcare and really try to incorporate everything we learn, really working towards kind of this ultimate goal of exceptional care. And I do this for moms and babies. I work at Ohio State. I teach. I love the nursing students. I spend a lot of time teaching in the BSN program, actually, for that. I do service in different areas of kind of community engagement at OSU and the broader community. And then I do a lot of research and science and scholarship. So that's the biggest part of my job.
For somebody who hasn't been in a NICU, for instance, could you maybe paint a picture what it's like to be in there with those families after they've had a preterm birth? Like, what are some of the complications you might see in that situation?
NICU stands for Neonatal Intensive Care Unit. So you can kind of picture an ICU, an intensive care unit, if you've ever been in one of those before, but the patient is the baby. And so when we say neonatal, we're talking about the first 28 days of life, but sometimes babies are in there much longer than that, just trying to grow, develop their organs, to be able to kind of survive outside of mom's tummy. It's very medicalized, of course, because those babies are going to need a lot of help. You'll see a lot of tubes, you'll see breathing machines. The babies that are born very early are going to be very, very tiny, can sometimes even fit right in your hands. They're so little. And there are exceptional nurses and healthcare providers. We have neonatal nurse practitioners as well that are in there just really taking great care of these infants. But for families, it's kind of shocking, of course. You know, this is your family, your baby, and certainly not what you expected when you're going into what should be some of the happiest days of your lives. So preterm birth is really the number one cause of why babies will end up in that NICU, is they just need some help breathing. They need some help taking in nutrients and just really kind of addressing and preventing other complications from happening. But anytime I talk to NICU nurses and people in that area of science, the conversation always stems to, how do we prevent this from happening? Because no baby, no family has to go through that. And it's just, it's a lot. You know, the care is exceptional, but it's a lot to go through.
Why is preterm birth so dangerous for mom and baby?
The very obvious issue for baby is that baby needs time in the tummy to develop appropriately. And some of our major organ systems are the last to develop fully, so the lungs being a great example of that. The earlier the birth, the greater the risk for that baby. Survivors have a lot of long-term complications. And then the rate of death is very high, especially if that birth is very early. We're talking 25 times the odds of infant death as compared to just if that baby made it to 37 weeks, just if it had enough time in the tummy. Globally and in the U.S., we're talking 1 in 10 babies, more than that, are being born too soon, so born preterm. That number has not budged. Black Americans are at much higher risk for preterm birth of their baby, much higher risk of infant mortality, and much higher risk of maternal mortality. And when you think about trying to identify the individuals who are at high risk for these different complications, it's really hard. It's kind of a needle in a haystack sort of situation. So what tends to happen is we just try to define, okay, what is good care? And we try to get people in to receive care. We try to give good care, but it's generally the same care for everybody. So to really find those who are at risk, why they're at risk, and prevent it from happening is a challenge, but so worth it, so important.
So what's in place now to help women with this preterm birth issue? What are clinicians able to do now?
What tends to happen is we would recommend mom to get in to see an obstetrician early on in the pregnancy, during the first trimester as early as possible to kind of establish that care. You'll have what's called a prenatal battery. So you'll have your blood drawn. They'll look at things like your blood type, complete blood count to see if you're anemic, things like that. They will also, at mid-pregnancy, complete an ultrasound. So in doing that, they can kind of look at the fetal anatomy. And then also oftentimes now they'll offer what's called a cervical length screening. They'll do a transvaginal ultrasound as well if mom so chooses to look at the length of the cervix. And if that cervix is getting quite short early on in pregnancy, then we have some indication that something might be happening there. So I mentioned that was kind of one of those things that we can see that can cause early labor. If mom has already had a preterm birth, then the care team is kind of alerted to the fact that there's a possibility, a higher possibility than the general population, that she would repeat that preterm birth. So that individual's at risk. We don't want someone to have a preterm birth to know that they're at risk for preterm birth. The very first pregnancy, we want to know why, and we want to be able to prevent that from happening.
And so that's where you come in and where your work comes in. You've really become a healthcare innovator along these lines, right? Talk about what you're developing to help mothers.
I set off initially to understand pathways to preterm birth. So we knew that there were these different risk factors, these different exposures, one of which being things like stress. So psychosocial stress, traumatic events, chronic stress, all of these things are things that increase risk for preterm birth. We kind of have this host of risk factors, but we don't understand how those get under the skin, how those affect the body in ways that then produce this outcome. I said, I'm going to dig into this really specific immune pathway to understand how these exposures affect mom's immune system and get some sense as to if and how mom's immune system is related to their risk for preterm birth. We started to say, if we take immune cells out of the body and really start looking at them, really understanding how they respond to things, can that give us insight then into what's happening inside of the body? So almost kind of this crystal ball of looking into the future and saying, if you had a urinary tract infection, how is your body going to respond to this? Is it going to respond in a way that's overly robust, right? Like kind of introducing inflammation to the extent that then mom and baby are at risk? Is it not going to respond? Are you kind of immunoparalyzed so that you can't clear the infection? It'll kind of continue growing and then you'll have issues in that regard. Or is there the kind of this sweet spot? So we started looking at all of those things, initially starting as a pathway. But when we really dug into the immune system and started looking at it in terms of multiple markers, really profiling it in this way to understand what that means in terms of responsiveness, we could predict risk for preterm birth pretty well. And we're starting to say, like, well, okay, if we look at this in the early third trimester, I have a pretty good sense of when that mom might go into labor. And so it was kind of this epiphany moment of maybe these are our clinical profiles that we could actually measure, repeat, measure, and act upon. So then kind of a line of research was born in that area. We don't just want to predict, we want to prevent. We want to say, are you at risk for preterm birth? Why are you at risk for preterm birth? And what will you respond to prevent that from happening? Scientifically, if we do these things in the laboratory that I do as a scientist, we can predict risk. The next thing in my head was, this will never be possible in the clinic, at the bedside. We have to find a way to change this to a clinical approach as opposed to a scientific approach. So this past year, I've been working with the Keenan Center, and we have some funding from Ohio Third Frontier to actually partner with the Center for Design and Manufacturing Excellence here at Ohio State. We're actually getting close to finishing that project, but we have essentially a kit, the mechanical components to be able to do this test at the bedside now. Because if you come up with a solution that is never going to be possible in the healthcare setting, then it is no solution. It has to be able to get to the patients and help the people that we want to help. So it's been exciting.
So between yourself and some other entities at Ohio State, this very multidisciplinary approach, we'll get to a place where a mother can identify almost right away that she might have a preterm birth and ways to treat it, right?
Science is a marathon again. So it's so exciting to find this. And then there's about 10 other steps that you have to get through to actually get it out to the patient. So it will continue to be a work in progress. We'll be testing in the next big study. It's going to be over 5 years, the algorithm in a large, we call it a clinically representative sample. So we're recruiting a very diverse set of individuals so that we can make sure that this test works for everyone, not just subsets of individuals. So that's kind of the first big step, is to make sure that we can reproduce this using a clinical method and it works for everyone. In doing so, there's also a component that we're identifying what I call the immunopathology. So there are several reasons that someone would test positive for this. So simultaneously, we're doing what I would term kind of a clinical trial in a dish in a way, where we're trying to understand, okay, if you are testing positive in certain ways, how can we reapproximate the function of your immune cells to what we would consider a low risk profile? So we can just do that with blood samples. And then the next step, is going to be, we call it a biomarker informed randomized controlled trial. But what that means is we actually do an RCT and we say, does knowledge of this test and the ability to act on that knowledge actually reduce your risk of preterm birth? A lot of good work to do. Exciting, scary. We all care so much that we want to do this right, and we want to make sure that we can get it to patients. So we're just trying to be very measured, deliberate, really think about the patient and the healthcare provider in every step of the way. So,
Shannon, thank you so much for this work. It's so incredible. And thank you so much for talking about it with us today.
Absolutely, yeah.
As Shannon said, sometimes science can be described as a marathon, and healthcare innovation might be an even longer one. Between discovery and implementation, there are questions to answer, systems to navigate, and trusts to build. And what makes Shannon's work so compelling isn't just the technology itself, it's the intention behind it, pairing a nurse's perspective with a scientist's rigor. And the cherry on top, an entrepreneur's determination to make sure an idea doesn't stop until it reaches the people who need it most. Because when innovation is grounded in compassion and driven by lived experience, it has the power not just to change outcomes, but to change lives. Now at Ohio State is produced by The Ohio State University. For more information, visit us at go.osu.edu/now. I'm your host, Matt Stessner. Thanks for listening.